Welcome, ladies and gentlemen, members of the Albertus Magnus College community, guests, and especially students. My name is Robert Bourgeois, and I'm Professor of Anthropology and Humanities at the college. The Justice Panel is a student-faculty collaboration aimed at addressing contemporary instances of institutionalized injustice. It's an expression of the Dominican pillars of prayer, study, community, and service. Our college is sponsored by the Dominican Sisters of Peace, whose twin peace and justice ministries call them to promote justice through solidarity with those who are marginalized, especially women and children, and work with others to identify and transform oppressive systems. The Justice Panels give students an opportunity to apply their skills of study and analysis in the service of solidarity and the common good. At this point, I'd like to acknowledge the support of members of the college community. Vice President for Academic Affairs, Dr. Sean O'Connell, Sister Ann Kilbride of the Dominican Mission, Jeremy Peterson of Information Technology, Professors Ross Edwards, John Sozek, Carol Huckabee, and Hallie Douglas of Dominican Ministries provided essential advice in planning. And a special thanks to Dr. Rosemary Whalen for co-sponsoring our Justice Panel and for bringing today's respondents into our program. Today's panel is jointly sponsored by Dominican Ministries, the Department of Biology, and the Health Sciences Program. The theme of tonight's Justice Panel is racial disparities in maternal health care. Some people of goodwill object to the phrase systemic racism. The phrase does not mean that individuals within the systems that produce disadvantageous outcomes for Black people and people of color are setting out to be racist or are consciously racist. The evidence for systemic racism lies not in individual intentions, but in patterns of disproportionate and race-related outcomes, which may in turn reflect implicit bias by institutional agents. Such outcomes would be violations of our constitutional principle of equality before the law and our aspirational principle that all men are created equal. And they are violations of the foundation of Catholic social teaching, which is the God-given and equal dignity of every human being. We look forward to learning to what extent tonight's presentation will shed light on the question of whether systemic racism exists. A word about mechanics. I ask you to put your questions, which will, during the Q&A period later in the program, in the chat box. We believe that will save precious time and help me assure everyone an opportunity to voice a comment. I'd like to introduce the speakers, beginning with the respondent and then the principal presenter. Ms. Nadine Lucien is a biology major projected to graduate in May 2021. Ms. Lucien has a profound interest in healthcare, particularly in relation to racial disparities in the system, and so was a natural choice as a respondent today. In addition to her scientific interests, Ms. Lucien is a certified nursing assistant at Casena Care in Norwalk, and has completed an internship at St. Vincent's Hospital in Bridgeport. A native of Haiti, she is fluent in Haitian Creole and French. Soyez la bienvenue, Mademoiselle Lucien. And our presenter, Leon Tanis. Known by her colleagues as a change agent and evolving leader, former finance executive and current student midwife, Leon Tanis, left her 15-year financial career to pursue midwifery and reproductive health. Leon's mission is to change the birthing profession for the benefit of birthing people, especially Black birthing persons and people within the LGBTQIA+ community. Leon is a Black and Haitian American with an engineering degree from the University of Pennsylvania. She is a certified nurse midwife and a women's health nurse practitioner, Master of Science in Nursing candidate at the Yale School of Nursing. She is currently completing her clinical studies in Washington, D.C. at the Community of Hope Family Health and Birth Center. Leon Tanis will speak for 20 minutes, and then the respondent, Ms. Lucien, will make a commentary of 5 minutes, to which Ms. Tanis will reply. We will briefly submit reflection questions for your consideration. Then the floor will be opened for comments and questions for our speaker. And now, please welcome our guest speaker, Leon Tanis.
Hi, everyone. Thank you, Professor Robert, for that introduction. I guess, can we show the presentation? Perfect. Okay. So, as Robert mentioned, I am here to speak about racial disparities in maternal care. Next slide, please. And this is just an overview of the topics, kind of how the conversation will flow. Next slide. So there's some important things to note. One, I have no financial conflicts. I wasn't compensated for doing this or for any or by any of the research that I included in this presentation. Where I can, I will use inclusive language, particularly around pregnant people. But much of the research is much of the research uses gendered language, so it does speak of women, maternal mortality, and basically assumes that anyone who gives birth is a woman, and it doesn't account for gender non-binary, gender non-conforming, and trans folks. I am a midwifery student and a reproductive health student, so I'm still in the process of learning. I do not have all the answers. And most importantly, I'm a Black woman, and my focus areas are Black people in the Black community. So the racial disparities are not limited to the Black community. There are racial disparities for Hispanic as well as Pacific Islanders and American Indian and Native Alaskan folks as well. However, I am not specialized in the reasons for those racial disparities. Next slide, please. So I wanted to highlight some definitions for terminology that will be used throughout the presentation. The first one being pregnancy-related mortality, sometimes referred to as maternal mortality, and that is the death of a pregnant person during pregnancy or within 1 year of pregnancy, regardless of how many weeks. That's what we call gestational age, how many weeks they were pregnant, or the outcome of that pregnancy. So did it result in a live birth, stillbirth, whatever the outcome is. The only exceptions are death from accidents or incidental causes. The maternal mortality rate is the number of deaths in a given period per population of people who are of reproductive age, and people who are reproductive age, according to the World Health Organization, or the WHO, are people between 15 and 49. Maternal morbidity. So this is terminology that means serious pregnancy-related complications that result in significant short-term or long-term consequences for the pregnant person's health. This presentation won't really delve into maternal morbidity. I more cover or more discuss maternal mortality. However, maternal morbidity is kind of the reason for some of the deaths that happen. So I will reference it in the presentation. Another one is infant mortality, and that's death of an infant before their first birthday. And then when I refer to Black people, I'm speaking of people of African ancestry in the United States. And these are some acronyms that will be used throughout the presentation. AIAN is American Indian and Alaskan Native. NHOPI, Native Hawaiians and other Pacific Islanders. So that's people of like Samoa, Guam, and NBPOC, non-Black people of color. As a Black person, I do not like to be referred to as a person of color. I do not refer to other Black people as people of color. And so that's why there's that differentiation. Next slide. So when we discuss racial disparity in maternal care, what do we mean? One of the first things that we are really referring to are the maternal mortality rates within the United States. the CDC approximates that 700 women die in the US as a result of pregnancy complications. That number is, some studies suggest that number is grossly underestimated because there isn't a standardized data collection and really kind of monitoring of pregnancy-related complications, meaning they could be classified as something else. But as it is now, approximately 700 women die. When you break down when those women die, a third of them die during pregnancy, 13% die between 6 weeks and 1 year of pregnancy, and then 56% die during labor or within that first week of pregnancy. Black women are 3 to 4 times as likely or have maternal mortality rates higher, 3 to 4 times higher than white women. These differences are also, that's kind of the national rate, sorry. There are regional and state differences. So for instance, in Illinois, which is blue state, home of Barack Obama, I think prides itself in being pretty liberal, Black women are 6 times as likely to die than white women due to pregnancy-related causes. In California, again, blue state, very liberal, prides itself in being very open, liberal, and it actually has the maternal rate overall is lower than the national average, and that Black women are still 3 times as likely to die in California. So I mentioned that just to show that I think a lot of people think that within the United States, kind of in your Northeast or Northeastern states or states that are considered blue, very liberal, have these open kind of healthcare policies and all of that, there still are these disparities, and it's not just a Southern state problem. Next slide. Oh, sorry. The other thing I want to mention is that the disparities persist across educational levels and increase with maternal age. And so looking at the educational level, among women with a college education or higher, Black women are over 5 times more likely to die from pregnancy-related causes than white women. And Black women with completed college education or higher, their pregnancy-related maternal rate is 1.6 times higher than that of white women with less than a high school diploma. So I mentioned that to say it's not necessarily about access. It's not access. It's not necessarily about social economic status. It's not necessarily about access to healthcare, because you assume that these college educated women have that access. Not necessarily about income level or education level. Black women are still dying and being affected in pregnancy care. Next slide, please. Another part of the racial disparity in maternal care is birth risk outcomes. So Black and American Indian, Alaska Native, Hawaiian, and Pacific Islander women are more likely to have certain birth risk factors that contribute to infant mortality that have long-term and short-term consequences in the health of children. So what does that mean when we talk about birth risk factors? So we're looking at things like preterm birth, and preterm means a child that is born before 37 weeks. 37 weeks is considered early term, so that means the infant is fully developed and can live outside of the mother. And then also we talk about low birth weight, and that is when the infant, they're born and they weigh less than 5.5 pounds. So really petite baby. And some of that can be contributed to the birthing person and what their kind of body habits is. So you have really petite people that have petite babies, or you can have people that just historically within their family, they birth small children. I have a patient right now where her baby is considered small, but her mom said, well, she was only 5 pounds when she was born full term. So some of it could be genetic, but a lot of it could be health related causes as well. And the fact is that infants born of low birth weight end up having higher risk of health complications down the line. Some of the things, kind of what these numbers indicate is really you look at prenatal care. So that first point, Black women overall have higher rates of preterm birth and low-term birth and give birth with little to no prenatal care in compared to white women. And this trend is also there for Native Hawaiians and Pacific Islanders, as well as Hispanic women as well. And so prenatal care, when you think about prenatal care, we're looking at monitoring the health of the pregnant person throughout their pregnancy. So looking at tests as well as doing assessments, lab work, and checking in, as the person becomes, or as they progress through their pregnancy, they're being seen more often by their provider. Managing any existing medical conditions that may impact their pregnancy. So managing and assessing and monitoring that, and then providing that health guidance and information and education. And so prenatal care is really important. And so if the patient doesn't have access, they can't come in, they're unaware, they don't have health care that covers it, or they don't feel safe. Sometimes patients just don't feel safe interacting with the health system. They aren't getting this prenatal care and therefore having these adverse birth risk outcomes. Next slide, please. So the birth risk outcomes can lead to or can impact your infant mortality rates. And so infants born to Black and non-Black persons of color end up having higher risk for mortality compared to infants born to white women due to those risks that we just discussed. So low birth weight, preterm birth. Looking at kind of that last point, Black women suffer higher rates of fetal death and stillbirth compared to white and Hispanic women. And that could be possibly due to maternal morbidity. So that's the serious complications that I referred to in the definition slide. And that could be gestational diabetes, preeclampsia, eclampsia, blood transfusions, anemia, or blood transfusions to combat serious anemia or severe anemia. And so the thought is those maternal morbidity rates are higher within the Black population, and therefore impact the infant mortality rate. Some infant deaths most occur within that first month and first month after birth, and the primary causes can be congenital anomalies, so something that's just genetic they're born with, preterm birth, low birth weight, maternal pregnancy complications. So if the mom had gestational hypertension, which is high blood pressure due to pregnancy, preeclampsia, which is high blood pressure, but it's actually now impacting my kidney function, my liver function, my platelet levels, SIDS, which is unfortunate sudden infant death syndrome, or physical injury. Next slide, please. So another part that I wanted to raise is this term called obstetric racism. And it was a term, I believe, coined by Dana Davis. And it's kind of at this intersection of obstetric violence and medical racism. So obstetric violence is something that all pregnant people face in the hospitals. And it's experienced by the person giving birth who's subject to violence as a result of or because they are an obstetric patient. So it's kind of outside of race. It has to do with your gender and the fact that you are pregnant. And then you have medical racism that occurs because of person's race. And so it's the way that they're treated, perceived, and diagnosed kind of as they move throughout the health system. The theory is that Black women or Black people and other non-Black people who are pregnant kind of are at the intersection. They experience both, right? And it's this term called obstetric racism. Obstetric racism can be, and I listed 7 things here, but it can definitely be a lot more. And I think it's important to note that as a Black person and a non-Black person of color, it's not like you experience one of these things. You usually experience all of them, and it's all just in combination and throughout as you progress through your pregnancy up through your labor to delivery and postpartum. A couple things that I wanted to note in this were kind of point 3. So intentionally causing pain due to lack of empathy or false belief that Black people have a higher pain tolerance. So this is not new, and it's something that isn't just limited to pregnancy. You can constantly hear stories of Black people going into the ER, especially you hear about it with Black people who have sickle cell anemia or sickle cell disease. That can be a very painful disease once it's flared, and they go into the hospital, and immediately they meet resistance when they seek pain control because they're seen as drug seeking. And that is something, this kind of belief that Black people have a higher pain tolerance is not a new concept. It actually goes back to enslavement times, and I'll kind of bring up and discuss that a little bit later. And then when you look at medical abuse, again, engaging in experimentation, focus on the power of the provider and not the birthing person. So kind of that person doesn't really have consent around or isn't empowered around their medical care. And that is something, again, that's not new. I want to, at this time, discuss a person in history named James Marion Sims, and he's often called the father of gynecology. And he lived in, I think, the 1800s. He was a slave owner and also a medical doctor, and he basically experimented on enslaved women. And a lot of, like, you will read, and there's some references or resources that I provide in later on in the presentation, where the study or the field of gynecology, a lot of it is founded on the experimentation of Black enslaved women. And so just to mention kind of this thread of experimentation of performing procedures without full consent is not something that is modern. It's something that is historical and very much built into the foundation of the United States through slavery. And I should note that he experimented on Black women without anesthesia. So again, based on the belief that Black women had a higher pain tolerance and couldn't necessarily feel pain in comparison to white women, because he attempted to experiment on white women as well. So there's very much a patriarchal arm to this, and you can't really separate patriarchy and racism. But he attempted to experiment on white women, but they couldn't handle the pain. And he found that Black women could, but didn't really take into account that they didn't really have another choice. It was kind of, they had to go through these or be whipped or killed. So kind of like you just had to sit through it. They were enslaved. Their autonomy, their bodily autonomy was taken away from them. And so I want to kind of take a moment to name, he experimented on multiple enslaved women, but there are 3 in particular that were mentioned because he actually wrote about them in the American Journal of Medical Sciences. So I just want to take a moment and name those women. And one woman, her name was Arnaka Westcott, and she was operated on as many as 30 times for a fistula. And he ended up perfecting his methodology on her, and then used it kind of to help cure other women of this process called a fistula. And then Betsy and Lucy as well. And not much is known about Betsy and Lucy because the journal didn't go into detail about them, which was standard practice, which wasn't standard practice. They actually usually talked about the subjects, except when it came to enslaved folks. And then racial reconnaissance. So that's like hypervigilance. And that's when the patient is aware of the need to advocate for themselves. But in addition, they're aware that their Black or non-Black provider or non-Black person of color provider also has to advocate not only for their patient, but also for themselves, and that they have to show that they have the knowledge and qualifications to treat this patient, and their plan is adequate, and kind of having to prove that. And it's this theory that the patient is aware of this. And so there's just kind of this hypervigilance that ends up happening where the patient knows not only am I Black, but now my provider's Black, and I know the challenges that they have navigating the healthcare system as a provider. And in addition to that, they also now need to advocate for their Black patient. And I think that one's important to note because I think people, there's a lot of discussion about increasing the number of Black and non-Black persons of color providers in the medical space, period, not just the birthing space. And that's not enough. It's kind of, the lack of diversity is a problem, but it's not the only problem. And throwing more non-white people at it in a system that's already racist and violently racist isn't going to solve the problem. And it's also just not fair on them to solve the problem. So more work needs to be done than just having more non-Black and non-Black persons of colors and Black providers in this space. So what does the whole picture of obstetric racism look like? Like, what are real life examples? And so I wanted to mention two. One is Kira Johnson. She's a 39-year-old woman based in Los Angeles, California. She was a mother of one boy. She was in the hospital to give birth to a second. And she was somebody who was considered, who falls in that population, being highly educated, came from an upper middle class background. Her mother's actually a judge, and was kind of was an upper middle class as well, married, the whole nine. And she went into the hospital, had a C-section with her second son. And after the C-section, there was blood in her catheter. And what that means is a lot of times when you are numb or you have anesthesia and you cannot get up to go to the bathroom. And it's really important that your bladder be emptied just in general, but also definitely with pregnancy. And so they insert a catheter into your urethra to help empty your bladder. And blood was in the catheter. And the husband looked at it and said, I don't think that that's right. Her urine is pink. Is there an issue? And her husband was told, your wife's just not a priority right now. And so a CAT scan was ordered. It never really happened. During this time, Kira is suffering. She has high pain. She kind of reports having a lot of pain. She's trembling. I imagine her vitals didn't look great. I imagine she had a high heart rate. She had low blood pressure. She was probably cold. And I imagine her color wasn't looking that good. And so the husband kept saying, hey, something's wrong, something's wrong. Told, your wife's not a priority. Now, this is post C-section, major surgery. People talk about C-section like you just go in, get cut, baby's out, you're sewed up, that's it. But you are cutting pretty deep. You're cutting muscle, you're cutting tissue, like it's a major surgery. And so finally, after 10 hours, they had a CAT scan. Or no, sorry, CAT scan was never done. But after 10 hours, she was taken back to the OR to get checked out. It turns out she had 3.5 liters of blood in her abdomen. That's why I said her vitals had to not look great because she was bleeding internally. And she ended up dying. Her heart stopped due to hemorrhage. And so she hemorrhaged for about 10 hours. So that's one example where you see these things that have happened. Diagnostic lapses, neglect. You can call it an intentional cause of pain because she said she was in pain. And I believe one of the responses that the husband got was that, well, of course she's in pain. Like she just had major surgery. And then you can look at number 6, medical abuse, kind of de-emphasizing what she's feeling as well. And then the second person I want to mention who's a bit more famous is Serena Williams. And if you don't know who Serena is a famous tennis player, top athlete, best in the world. And she was known to have a pre-existing condition, blood clots. This was pre-pregnancy. She had shortness of breath. It was ignored. She had a C-section and started immediately having shortness of breath. She told the nurse. The nurse just assumed it was her pain. It was her pain medication that was talking. Like she wasn't really, she was really serious, and kind of told her to go back to bed. And Serena knew well enough that no, this is not. I'm familiar with blood clots. I know what's going on. And so she really had to advocate for herself. And she suffered a couple things as a result of that. Her C-section wound reopened because she was coughing due to the shortness of breath or difficulty breathing. She had a hematoma, which is basically just a massive blood clot that causes swelling. And she had what's called pulmonary embolism. So these small blood clots in her lungs, which can lead to death. And so it was finally addressed and cured or treated. But she's someone who is ultra wealthy, famous, well-known, has a white husband, and also was known to have this pre-existing medical condition and still wasn't heard. And you just kind of think if somebody like Serena Williams can't be heard, where she most likely, I would imagine the patient to provider ratio is pretty low because she's a VIP as well. And they can't take the time to hear her. Somebody who's just regular like myself, like what chances do I have of surviving the medical system during birth? Okay, next slide, please. So reducing these racial disparities, how can these be reduced? I've listed some here and that I'll go through, but I just wanted to note that trying to reduce racial disparities within while trying to maintain a racist system is pretty difficult. So I will sit here and say I'm not 100% believer in a lot of these because I believe that the systems need to be dismantled and rebuilt, that you cannot fix a system that's already built on racism. So, but however, that's not like the overarching belief. So I've listed these here, but I really do feel like, it's kind of two-pronged. You can dismantle the system while trying to address these as well, but there has to be an active dismantling of the system as well at the same time. So the CDC believes that as many as 60% of all maternal deaths in the U.S. are preventable. They suggest that reducing the disparities requires participation of the multiple systems. So looking at your health system, your healthcare system, hospital systems, looking at all the players within the system, getting them together to address the factors that are perpetuating this problem. Increasing access to reproductive and prenatal care, definitely by expanding Medicaid to include all birth workers. So it's not just your providers, your midwives, and your, by providers, I mean like your midwives and your OBs or obstetricians. It's also the other people looking at labor support people. So some people will refer to them as doulas, lactation support as well. And your doula can be there prenatally during labor, and also they have postpartum doulas, which are really important because that postpartum period is just as important as that prenatal period. Improving the quality of care to pregnant people. So looking at assisting these populations navigate healthcare settings. There are patients that I have that just refuse to interact with the hospital system. So they might come in for their couple prenatals, come into the hospital, and then we don't hear from them again. And it's usually because they have had an incident involving the hospital system or the healthcare system. And so it's very traumatic and triggering to constantly to have to now engage it, or they have a family member that has. Addressing maternal and infant mental health. Mental health, I think, is a huge part of it, again, because of some of the trauma that comes with trauma related to birth, as well as just people that are high social risk. So you have housing, people that lack housing, food insecurity, these sorts of things. It's kind of like really addressing the whole person. Supporting the families, like I was saying, before birth is important, but after birth is just as important. And definitely getting what the actual numbers are. What are we really looking at here? And the thought is that it's worse than we thought. Next slide. So these are some of the organizations that I know of that are doing the work. Full disclosure, I am on the board of the National Association to Advance Black Birth. But these are all organizations within this space that I know of that are doing a lot of great work. Sister Song is doing great work around reproductive justice. And next slide. And then lastly, these are some of his suggested resources if you want to find out more information. Birthing a Slave, Motherhood and Medicine in the Antebellum South talks a lot about what I was referring to with Marion Sims. Killing the Black Body, Race, Reproduction, and the Meaning of Liberties by Dorothy Roberts. Read anything by Dorothy Roberts. She's great. She's a sociologist that really kind of draws that thread to show the origination of a lot of the practices, the harmful practices within the medical space. Medical apartheid and medical bondage are both great, talking about experimentation, and medical bondage is really great around the origins of American gynecology, and you kind of see where a lot of these things come from. The last three, they don't necessarily deal with reproductive justice or racial disparities within healthcare, but these are three folks that have really influenced my thoughts in this space and really helped what I call kind of decolonize my mind. And they're just great folks to read and follow on social media. And next slide. And these are the references that I use just for folks if you wanted to read more about some of the things that I posted. And that's it. Thank you.
Thank you so much, Leon. Thank you very much. And I'd like to go directly to our respondent, Nadine Lucien. So here we go.
Hi, I would like to thank Ms. Denise for her fascinating presentation. I have learned a lot. Thank you so much. Well, it is one of the least talked about subject when it comes to healthcare in America. Disparities in the care of racial minorities do exist. It is shocking to see the data on this as presented by Ms. Denise. It is recognized that the healthcare in the U.S. lags behind when compared to the rest of the of the world, it is very distressing to see the disproportionate bad outcomes for Black and other minorities in maternal settings. Well, knowing that the US has the highest rate mortality and pregnancy-related death, and adding racial disparity to that, it is obvious that we have an issue in the healthcare system that needs to be solved so that Black and other minorities can have better treatments before and after giving birth. It saddens me to see the effect of racism ingrained in the U.S. health system has on infant mortality. I don't think it matters, as Ms. Denise said before. I don't think it matters where you come from or your social status, but as long as you fall under this umbrella where you're Black in America and also part of the minority group, you are subject to face racial disparity in the healthcare system. I was talking to one of my good friends. She is a medical student and also she is specializing in OBGYN. She told me about a myth in the healthcare system that Black people, they have higher tolerance pain when compared to a white person. So coming from an overexploited country where I have seen women dying from pregnancy-related complication cases, these cases, they are preventable, but the hospital there, they don't have the equipment to intervene. But here in America, we do have the equipment, so we do have what it takes to prevent those deaths, but we're not doing anything about that. This is very scary. When we take the example of Serena Williams, she was having complication. After giving birth, she told the nurse and nothing was being done. And if the nurse had took action when she had told her that what was going on with her, none of that would have happened. And this is really, really scary. And I'm going to end by thanking Ms. Denise for her presentation again. Thank you so much.
Thank you, Ms. Lucien, very much. Since we're a little behind where we were on schedule, Leon, if you wouldn't mind, I would like to flash the reflection question onto the screen for people just to write down. We won't take the full 5 minutes for that, but I'd just like people to jot down these questions. And when we have a little more leisure, when you have a little more leisure, then jot down your thoughts. All right. Thank you for that. Now, I'm going to suggest that perhaps if you have a reply, Leon, to Ms. Lucien's comments, perhaps you could make that brief and we could open up to comments from the floor.
Okay. No, I think Ms. Lucien, what she kind of picked up and highlighted was right on point around the disparities and the impact of those disparities on the community and the surprise I think that most people find about these disparities, especially the cause. I think people feel that they're access related, they're related to income level and more social status. When you look at Black women, you can clearly see that they aren't. So.
Okay, so thank you. Now, I'd like to open the floor to people's comments and questions, and I'm going to go to the chat box. So let's see, let me see. Here's one. Is there any association between the age of Black women and the deaths? I assume he means the deaths of Black women.
So in my research, I didn't focus on that. I know that the rates increase with age, but I didn't see, like, I'm guessing the question is saying, the question was about the association between the age of Black women and the number of deaths, meaning like potentially saying maybe their age is the cause.
Yeah.
To do with it. Yeah. So no, I haven't seen research that kind of contributes to the person's age.
Yeah, actually, I was reading an article. It did mention that for Black women from the age of 20, they're 1.5 times more likely to die when compared to white person, and also from the age of 30 and above, it is 4.3 times more likely for them to die when compared to a white person.
Yeah, but I would just be careful with that because I would not put it on the age of the woman. That kind of attribute their death, like their age, their death to their age, or say their age had a role to play in their death. I would still think that race might be the more important factor there.
I have another question here. Is there a way to educate Black women and other women of color on advocating for themselves during pregnancy and childbirth, such as which individuals or agency in the hospitals that can help them? I guess they're asking if, is there someone who can stand in who's the champion of pregnant women who are undergoing hospitalization so that they have someone who can advocate for them? That's the way I'm reading this.
Yeah, so there is one.
Yeah, and not just advocacy, but she emphasizes education. Excuse me for that. Sorry.
No problem. So there's a couple things. There are organizations that do work to educate, or I wouldn't say educate, empower Black women in these spaces. And like, for instance, the National Association to Advance Black Birth has created something called a Birthing Bill of Rights to inform patients about their rights within the hospital, to avoid some of these pitfalls. Well, I wouldn't say to avoid, but to help them be aware of these pitfalls so that if they see it coming, maybe they can just be aware of kind of what's coming their way. And a lot of people say this is why doulas are so important in hospitals, because it's somebody else to help support and advocate for the pregnant person, so that they can focus more on their labor versus now I'm having to fight the system while laboring. And I think that those are kind of the two that come to mind around kind of advocacy within the healthcare system. There's another one, but completely slipped my mind. So sometimes kind of advocating for yourself can be double-edged sword, because you as the patient can be seen as being difficult. Like, say you don't want to consent to certain procedures. You can be labeled as difficult in the hospital or within the medical system. If you're asking for more information, if you want to take the information and just sit with it for a little bit, do a little bit of research, that's kind of the flip side of it, is that you can be viewed that way when you're just trying to advocate and educate yourself.
I have here a comment, Leon, that relates to the impact of social policy on morbidity factors or outcomes. And it's this: I was interested to learn that medical racism versus access was a more important factor. I am reading, it found that between 2014 and 2016, infant mortality rates fell in states that had expanded Medicaid, while rates rose in states that did not. In addition, in states that did expand Medicaid, infant mortality for African American infants fell by more than twice the rate that it did in non-Medicaid expansion states. You have any comment on that?
No, so, I think that speaks to the point that I made on slide 9 around ways to reduce some of these racial disparities, and that was increasing access to reproductive and prenatal care.
Mm-hmm.
So, you can include those things in there.
So we have, we have several comments that are just expressions of outrage. But one says, this is a national disgrace and part of systemic racism. Please, and just hold on a second. I'm going to read several at once, okay? Because they kind of are bunched together in their theme. Please discuss basic steps we can take to interfere. Another one, how can white people appropriately serve as advocates for pregnant women and women of color? And and then a comment that at one point during the 90s, New Haven had a birth and infant mortality higher than most third world countries. So that's a combination. That's just a comment that speaks to the state of, and she doesn't, she doesn't, that doesn't specify race, but it just says something about the state and the comparative efficiency and safety of our medical system versus others. But a couple of people talking about what intervention can be take, what measures could be take to intervene in this problem.
That's one I don't necessarily have an answer for, other than, I think back to the person's comment around medical racism versus access, and thinking about a little bit more. I think one is advocating for Medicare or Medicaid to cover these things, even if you're a person that does not need or qualify for Medicaid, because you have your private insurance. Still advocating for those who do not, and to expand those services, even if it's something that doesn't affect you. And, that's kind of one way I can think of it. Another way is supporting these organizations that are doing the work. So supporting them with resources, whether they be financial resources or providing platforms for them to educate people. Because I think that's the biggest thing, is that there needs to be an awareness that this is going on as well. Those are some things that kind of come to mind in terms of what folks can do that might not be personally impacted by this.
Thank you. There's an interesting question here. What's the state of research on prison birthing practices? Have you come across that information about that?
Yeah, so I had to write a paper on this in school. Prison birthing practices are actually pretty terrible. I don't know of them kind of it being broken down by race, although the majority of people in prison, I believe, are non-white. So, it depends on, I think, the prison, if you don't get me wrong, but like women can be shackled to beds, or pregnant folks can be shackled to beds during labor, which is terrible. You can have a security guard sitting in your room the entire time. I've read stories of security guards sitting in your room the entire time while the person is laboring, with their television on loud, or radio on, just completely not having respect for the person in that space. To my knowledge, it's not great. It's not something that is very much supported. A lot of times the person might be laboring on their own, if I recall correctly. They don't have a support person in there. And then actually, this is an instance where providers don't actually have that much power in these spaces. I've known of providers that have requested and demanded that the person be unshackled while a pregnant person's not running off and escaping while they're in the middle of labor. It's just not happening. and they have advocated for that and have been unsuccessful in getting that done. And so it's kind of torture.
That's a sobering comment. There's a comment here that says, there is so much progress that needs to be made in the medical field with even properly diagnosing diseases and illnesses due to lack of appropriate data. Does that ring a bell with you? She has a link here that says, I'm sorry I can't show it to you, but a medical student couldn't find out how symptoms look on darker skin. He decided to publish a book about it.
Yeah, so, sorry.
Go ahead.
Yeah, so, I mean, that was one of the biggest critiques that I had about my nursing education, was that a lot of, if you want to look at kind of derm processes, so anything kind of regarding the skin, was shown on white skin. So, for instance, if you want to talk about pulmonary embolism, the thing that Serena Williams had, one of the symptoms of that is you get petechiae, which are kind of these spots on your chest, and they're kind of capillaries that have burst. And they showed it on white skin, and it looks like these red dots. And on somebody of a darker complexion, you're not going to see red. Red is not something that you see that indicates an injury, that people a lot of times will use as a sign of an injury. Sometimes it might show up as purple. We didn't know what that looked like. What's called cyanosis, which is kind of when you start turning blue due to a lack of oxygen. Your lips turn blue, your hands can turn blue. That you might not, blue is going to look different on a person of darker skin than white skin. So that's definitely, derm is a good place, as well as what they call med surg, which is kind of like general med in nursing school, where a lot of subjects used were white. And so nursing education, I will speak for nursing education, we are taught to treat white bodies, white thin bodies. We are not taught to treat people who are not white and who are not thin. And so there is that gap for sure, at least in my nursing education.
So, Leon, there are several comments here that are thanking you very much. Thank you for this powerful presentation. This was so important to share. Thank you. My daughter is looking to do her PhD in Africana Studies in regard to social justice, and I shared with her that you were speaking to us, and there are numerous comments like that. Thank you for sharing all of this information. Black women and other women of color need more support, care medically, especially before, during, after childbirth. And wow. So we have a big wow to express to you, and a big thanks to express to you. I'd like to ask Jeremy to put on the screen, perhaps. I put the contact information. If you, I don't know if you can you see that? Oh no, I didn't share that with, there it is. Okay. This is the contact information of our speakers. And I just want to say to everyone who's come, that I'm sure you agree this has been an illuminating and rewarding, if very sobering, discussion. And I want to thank you, and I wish we could all applaud. I wish we could all applaud loudly, but I'm going to assume that I express your feelings when I thank you, Leon, very, very, very much, and with great feeling of gratitude for educating us and taking time out to help us understand this. And without knowledge, and we can't confront the problem. So thank you so very much. We really, really appreciate it.
Thank you. Thank you for the opportunity. I'm sorry I went over. Thank you.
No, we're perfect. We're perfect. Right on time. So thanks a million, Leon. And thank you, Ms. Lucien, as well. And thanks for everyone for coming. Many more expressions of thanks all the way down. It's filling up, Leon.
Thank you.
Thank you. Thank you.